A very good morning. I think I should start now. Yeah. So good morning and welcome all of you for today's session on genetic testing for pediatrician. So this session is basically intended to give you a primer about clinical genetic testing and also to discuss the key findings, key points and consideration before you recommend genetic testing for clinical diagnosis. So before starting, just like to give you an overview, like what is a genetic testing? Basically, it is a type of medical testing technique for identifying changes in the genetic material of an individual. It can be anything, chromosomes, DNA, gene, or even the nucleotide-based space. I'll be discussing about the different scenarios where you can apply this kind of testing. So I'm sure you all of must be knowing about different types of genetic testing, and broadly they can be divided into two categories. The first one is medical uses and the second one is non-medical uses. So in the medical uses, the first kind of test which comes in our mind is diagnostic testing. So in this type of testing, either we confirm a disease or we rule out a disease. So now once you have received a genetic defect in a clinical setting, so we can use this information to go ahead with the carrier testing. So what is a carrier? A carrier can be an individual who may be not showing any symptom, who is asymptomatic, but carrying the faulty gene to the next generation. So next scenario is prenatal testing. Prenatal testing is done at the fetal stage to look for the congenital anomalies and birth defects. And newborn screening is done in the newborns for a battery of monogenic disorders, such as inborn error of metabolism. Next is predictive diagnosis. Predictive diagnosis, the risk of developing a particular disorder throughout the lifetime is estimated, such as in the case of breast cancer. Next one is pre-implantation testing. It is done in the case of in vitro fertilization in IVF, where the embryos are tested for the chromosomal abnormalities or grossly the aneuploidies before being implanted into the uterus. In pharmacogenetic testing, as the name implies, the genetic determinants in response to certain drugs can be tested. So coming to the non-medical uses, among the non-medical uses, it is used for the paternity testing. It is done in the members of a family to find out whether they are biologically related or not. The next one is genealogy testing. It determines the lineages or ancestry of a family or an individual, and forensic testing is done more commonly in an individual for the legal purposes. So when we are talking about the genetic test, one obvious question comes in our mind, like when one should go for a genetic testing. So first and foremost is the family history of the disease. So when a patient presents in a clinic, a clinician asks for the family history of a disease and maps the family members on the pedigree. Then he or she may suspect the pattern of the genetic disease in a family. Whether it is segregating or whether there are multiple family members in the different generations. So this is an indicative of a genetic disorders, and such cases should definitely be considered for the genetic testing. Other scenario, like if there are some rare or undiagnosed disorder, when a patient is critically ill and the diagnosis is very broad, very heterogeneous, and you don't have any clue, then you can consider taking a genetic test. So now there are numerical examples in the literature where genetic testing has made a significant difference in the clinical intervention or management of a disease. So also diagnosis can be made for which the treatment can be available. It can be used for the carrier testing or for planning a child. Interestingly, the benefit of a diagnosis is not limited to an individual or a family, but it can be extrapolated to an entire community. For example, if there are suppose multiple families in the same community showing the same kind of phenotype, which is not uncommon in India, so from the genetic defect identified in a family, what can be done? We can develop a simple diagnostic assay which can be used to screen the entire community. Before going deeper to the different diagnostic testing, let us understand the difference in between the screening test and a diagnostic test. So screening tests are intended for a people or a population who are not showing any symptom, who are asymptomatic, whereas diagnostic test it is used and targeted for the person who are actually asymptomatic. So there are few advantages of screening testing, like you can detect the disease at very earlier stage. You can provide surveillance based on the screening test. It can help to reduce the risk of disease, and also indicate whether the diagnostic further testing is required or not required. Just take an example of complete blood count. So by looking at the report, one can tell whether the blood counts of an individual are normal or not. If there are some abnormal counts for any specific kind of blood cell type, then you may need to go for any specific diagnostic test based on the CBC report. So basically, CBC is a kind of screening test to look for the overall health. What happens in the diagnostic test? It is used to confirm the diagnosis or to rule out any suspected genetic condition. It can also guide you regarding the treatment and management of the patient, and also it can estimate the risk of passing the disease to the next generation. So whether it is clinical testing or screening testing, one thing remains common and constant in both, that is the concept of informed consent. So as the name suggests, it refers to the information that a person taking genetic testing should know about, and then only voluntarily give the consent to participate in the genetic testing. So this information includes the description and purpose of the test for which the patient is being enrolled, how the test will be carried out. They need to know how to do the interpretation of the results, whether the confidentiality will be maintained throughout the test, what are the benefits and limitations of the test, and whether there are any physical or emotional risks are associated. And also the very important thing, like the sample of the patient or results, it is going to be used for the research purpose or not. So, or whether the testing may provide the information to the other family members. So another good thing is here, that a patient can change his or her mind even after giving the consent also, and can choose to withdraw his or her sample from the genetic testing in future. So informed consent and pre-test counseling is very, very important part of the genetic testing whenever you are offering any kind of genetic test to the patients. So after taking the consent, the sample for genetic testing can be collected. So the method of sampling depends on the type of genetic test you want to go ahead. For example, the simplest is the cheek swab. It can be saliva. Most popular is peripheral blood. And in the case of newborn, the newborn heel prick sample, which is taken on the filter paper, can be used for further testing. And in the case of prenatal testing, amniocentesis can be done, in which the amniotic fluid surrounding the fetus is taken out using the help of a needle, which is piercing through the abdominal wall of the mother. CVS is little tricky. In this procedure, a small tissue from the placenta is taken for the testing. After all, from all these samples, we used to extract the DNA for further going ahead for the genetic testing based on the requirement. So there is a range of genetic tests available, which differs in the terms of the resolution. So if we talk about the microscopic level, suppose you want to look for the entire chromosome, you want to see the number of the chromosome. So the best method is the karyotyping. If you want to go more deeper into the submicroscopic level, you can go ahead with the FISH or chromosomal microarray array CGH based on your requirement. And even you can go up to the level of changes in the DNA sequence. That can be done through the MLPA, Sanger sequencing, or next generation sequencing. So there are different types of genetic changes. First of all, at the level of chromosomal changes, so it can be either the numerical change or it can be structural change. So numerical change means the number of chromosomes are either increasing or decreasing. Just like in the case of Down syndrome, there are 3 copies of the chromosome. Even there can be one extra chromosome like XXY. There is one extra chromosome in the males. Or also in the structural anomalies means there can be a deletion of an arm of a chromosome. There can be a duplication of the arm. There can be inversion in between the chromosomes. There can be translocation. The DNA changes can be of different types, like there can be point mutations. Point mutations means like any variation in the DNA which is leading to the change of substitution, insertion of a single nucleotide. There can be indels also. Indels refers to the deletion or insertion of few base pairs, typically less than 50 base pairs. So these are the kind of changes which can occur in the genome. So chromosomal tests are basically used to detect chromosomal abnormalities such as loss or gain of entire chromosome or even deletion, duplication in some part of the chromosome. So classically, karyotyping is used to detect such abnormalities, but it has a very low resolution. So there are other methods also to screen the chromosomes like array CGH and SNP microarray, qPCR, NGS. I'll be telling about all these methods. All these methods differs in the terms of resolution. First of all, coming to the very basic traditional karyotyping. So this is a method or procedure to examine the entire chromosomal picture of a individual. You can look for the size, you can look for the structure, you can count the numbers. What happens? First of all, we take the blood samples, we put it for the culture for next 2-3 days. Then the cells are arrested at metaphase with the help of colchicine. Then we stain the chromosome with the help of, most commonly, Giemsa stain is used. And that metaphase then is spread on a slide by dropping over it on a glass slide, and that glass slide can be visualized under the microscope. So you are going to get a karyogram of the patient. So this is the normal karyogram. By looking at the picture, you can count the number of chromosomes and look for the gross abnormalities if there. So on the basis of the size, centromeric position and banding patterns, chromosomes are arranged. So no need to arrange it manually. There are softwares which used to do it for you. And there are certain conditions where you can directly go ahead with the karyotyping. No need to go for the advanced testing. Just in the case when there is a Klinefelter syndrome, Klinefelter means there is one extra X chromosome in the males. In the case of Edwards syndrome, where there is a trisomy of chromosome 18, in the case of Turner syndrome, that is XO, like there is a monosomy of chromosome X. Next is Patau syndrome, like trisomy of chromosome 13. And Down syndrome is the commonest one, where there are 3 copies of chromosome 21. Certain advantages and limitations of each and every technique. So what happens in the karyotyping, the advantage is like you can detect the larger deletions or numerical structural variations, more than 5 MB, you can say 5 to 10 MB is the range. It is easily accessible and affordable, and it can give you the information about the balanced translocation. Limitations like the preparation of the chromosome, it varies depending upon the tissue used. It is labor intensive and low throughput. The detection limit is low because of the resolution, and microdeletion cannot be detected. Whether if there is some interstitial deletion or duplication are present, which are not microscopic, that cannot be visualized through karyotyping. Next is FISH. So first of all, FISH is fluorescent in situ hybridization. So first of all, your DNA of interest is denatured. Then certain fluorescent labeled probes are also denatured. Both of them are then hybridized together and observed under the microscope. So deletions, duplication on specific chromosome arms can be detected by FISH, and there are different types of FISH available. I'm not going to the details in the methodology part. First one is locus-specific FISH, where the probes are designed specifically to the any particular locus or regions on the chromosome. So next one is chromosome-specific FISH, where the specific arm of the chromosome is stained with the use of a probe. Next is qPCR. Whenever you are suspecting any telomere-associated disorder, you can use the qFISH because it will use the telomeres of the chromosomes will be stained. MFISH is multicolor fish. As the name implies like all the different chromosomes are stained with the help of different colors. There are 4 to 5 basic colors which are used in the different shades, and by looking at the color, you can tell about it is which chromosome. So it can be used to detect the deletion or duplication of a specific region. It can tell you the changes in the multiple myelomas. Also, specific changes means suppose you want to look for the Smith-Magenis syndrome locus, so you can directly go for that particular fish. You can look for the translocations, and there is very common BCR-ABL fusion, gene fusion, which is detected in chronic myeloid leukemia. So fish is very good technique to detect all these things. So certain advantages like it can be used to detect submicroscopic changes in the chromosomes. Specific probes can detect changes in the specific regions of the chromosome. It is easily accessible and affordable. But the limitations like you cannot use it for a very broad or heterogeneous disease diagnosis. Not specific, sometimes what happens, there are non-specific binding of the probes which can lead to the background noise. This is our advanced technique, which is microarray. It is generally known as SNP microarray or array CGH. Array CGH means array comparative genomic hybridization. It is a technique to detect copy number variations. So what are copy number variations? So deletions and duplications which are more than 1 kb in size are known as copy number variation. So microarray can be used to detect such type of copy number variations. So what happens here, we take a patient sample, we take a reference sample, we label them with different fluorescent probes, and then it is hybridized. over a chip. So there is a glass chip on which your different probe sets are attached. We need to add our sample after denaturing, and it will give you a different type of signals. So based on the signals, this slide is being scanned in a scanner, and you can tell whether there is a deletion or duplication. And by looking at the graph, one can tell you about the deletion duplication information. So the example of various conditions where you can offer it, because the benefit is it is covering the whole genome. So you can tell about the microdeletion duplication syndromes, even the subtelomeric deletion and unbalanced translocation. So this is how it looks like actually. This is a complete chromosome number 12. Here you can see the probe distribution are coming on a same plane. Where there is a probes below this line, it will show you the deletion. If the probes are above this line, you can tell that there is a duplication. So advantage is like it can detect copy number loss and gains in the entire genome. And the advantage of using SNP array, it can tell you about the loss of heterozygosity also. Like only LOS regions can also be screened by using this technique. The limitation, like it can not tell you about the information about the balanced translocation. The cost is very high. Another advantage is like you can even tell about the breakpoints, and whatever the gene content present in that particular region can also be told by using this technique, which cannot be done by any other technique. This is our lab of microarray in APC. We are offering it for patient care now. So there are few scenarios when you can offer the chromosomal microarray to prenatal testing, which is very important in the genetic setup. So the conditions where you apply, you can use this chromosomal microarray testing is like, if you have some abnormal biochemical screening test, if you're getting some abnormal ultrasonography, if one parent is carrier of a balanced chromosomal anomaly or chromosomal disease in a family history, or if maternal age is more than 32 or 35, you can go ahead with a prenatal microarray as a screening test. Now coming to the MLPA. MLPA is a multiplex ligation probe amplification. It is a technique to detect structural variations in genome using specific probes. So this is very efficient method. It very less time, only 48 hours. It takes 48 hours to get the results. You can detect a number of different conditions within a single probe set. So like in the case of DMD, the gene is very big. There are 79 exons, and the most 60 to 65% cases are having deletions. So it is a very good approach to do the MLPA for DMD. So, and also in the case of SMA, spinal muscular atrophy, it can be done. There are n number of conditions where you can do the MLPA. So this is a normal graph where you can see that this is the probe distribution which is coming in between this bar. If it is here on the x-axis, you can see if there is 1, so it means like there is no copy number changes, like there is no deletion or duplication. But if you are getting your probes on 0.5 means it is showing a heterozygous deletion. This is a case of a SMA carrier. So this graph is showing that there is a heterozygous deletion in SMN1 gene, which is showing the carrier status. If the patient is affected, you are going to get the probes on level 0. It means there is a homozygous deletion in a particular gene. So it will tell you about the carrier status. It can tell you about the affected status. It is very efficient method. So advantage is like you can detect locus specific small deletion and duplication. It is a multiplex PCR. You can screen 40-50 condition at one go. It is high throughput and cost is very low as compared to microarray or other higher techniques. Limitation is like it cannot detect you LOH or copy neutral changes. It is very sensitive to impurities, and it is very sensitive to the variants present in the probe binding site. So it can sometimes give you false result also. These are the common tests of MLPA which is available at our lab. We are doing common microdeletion syndrome. We are doing SMA. We are doing DMD. MSMLPA is methylation specific MLPA for Angelman Prader-Willi, and also we have started doing it for CAH. So this is the list of common microdeletions which is this probe set covers. So for all these disorders, you can order a single test, that is MLPA, for this probe set P245. It covers near about 45 monogenic disorders. Now coming to the Sanger sequencing. So in the case of Sanger sequencing, one can look for a genetic defect in a specific region less than 1 kb region of a genome. It is very accurate and considered as a gold standard for validating the NGS data, or even doing the sequencing for small genes or a specific region. I'm not going to the methodology part, but There are few examples, like if you are suspecting a monogenic disorder and the gene responsible for the disorder is very small, just like a case of thalassemia, the gene is HBB and there are only 3 exons, then you can directly go ahead with the Sanger sequencing. No need to go for the NGS. If you are suspecting sickle cell anemia, there is a specific mutation for that, then in that case you can do Sanger sequencing. In the case of cystic fibrosis, delta F508 is the commonest deletion. You can directly go for the Sanger sequencing. So this is the chromatogram picture, how it looks actually. So there are 4 different colors for ATGC. By looking at the sequence of these peaks, you can tell the sequence in a gene of a nucleotide for a particular disorder. Advantage is like you can identify as a single nucleotide changes and small indels. It is cost-effective technique for a small number of targets. The limitation is like only specific region of interest can be amplified and sequenced. It is low throughput and scalability. I mean, if the gene is small, then only you need to go for the Sanger sequencing. If you are not sure if there are more than 1 genes are responsible, then Sanger sequencing is not the accurate technique to go for. This is the list of hotspot mutations, common mutations, which we are offering through Sanger sequencing in APC in our lab. Where there is a common mutation present, we can directly go for the Sanger sequencing for these disorders. Now, the most nowadays most popular technique that is next generation sequencing. So this is a just cartoon picture of a gene. Like here you can see these colorful bars are showing the coding region of a gene, and the black one is non-coding, that is intronic region. So again, I'm not going through the detail of the methodology, otherwise it will be complicated. I'll just tell you what are the different options of NGS and available and when you are going to offer all these types of tests. So first one is targeted NGS, that is candidate gene panel, in which one can test multiple genes at once. A panel can have as few as 4 genes, as in the case of familial hypercholesteremia, and it can be more than 50 or 100 genes in the targeted testing, like in the case of rasopathies, inborn error of metabolism, or other immunological disorders also. In other conditions where there are there are about 30-40 genes, you can make a panel and go ahead with the targeted testing. So the good part is like you have a set of genes, the analysis part is very simple in that case. You can identify the variation in any specific gene or region you are detecting. But the thing is that you cannot cover the novel genes in the case of targeted testing, but you can get novel variations which are present in that set of genes. The next, going ahead with the whole exome sequencing, which actually tests the whole coding exons of all the 22,000 genes present in the genome. It has already been seen that whole exome sequencing is used when targeted NGS is negative. So the rate of getting a diagnosis, it increases by 16%. And the cost-wise, nowadays, whole exome sequencing is coming almost very close to the targeted sequencing. So advantages here, like you can get even the novel genes you can get the novel variations, you can get the splice site variation, and few intronic regions are also covered to give you an idea. So in whole exome sequencing and clinical exomes are 2 different things. Clinical exomes means you're covering the genes, like 6,000 genes, which are directly associated with some OMIM phenotype. And whole exome sequencing, you are covering all the 22,000 genes, whether still they are associated with any phenotype or not. Then the next one, the most complicated one, is whole genome sequencing, which is an untargeted approach of sequencing. Even the intergenic, intragenic, regulatory, promoter, 5', 3', deep intronic region, everything is covered here. And the resolution is as higher as you can go ahead with a 1 base pair. But the analysis part is tricky. You need to have massive information about the bioinformatics. Here the advantage is novel genes, novel variations, novel non-coding regions can also be discovered by doing this. So there are various conditions where we can offer NGS test. Like if you want to look for there's very heterogeneous or a broad phenotype, and you are not sure about what to do, then you can choose the next generation sequencing, either the panel or whole exome sequencing as per your phenotype or disease etiology. It will tell you about the insertion deletions also, and nowadays very new algorithms are coming which can even tell you about the structural variations also. Even the inversions and insertion, deletions, duplication, everything can be done through NGS. The advantage is like all type of SNVs and most of the structural variants nowadays can be covered through NGS. It is high throughput, fast turnaround time, And the limitation is the cost is a bit high. It is not easily available at every lab, and it requires a lot of computational expertise and resources. So till now, we have understood the range of genetic testing that can be performed, but the challenge is now to choose an appropriate test in your setting. There are some points that one need to keep to ponder upon before choosing a suitable genetic testing. So let us discuss how to choose a test based on these factors. First of all is a diagnosis. If you have a diagnosis which is very narrow, or you have a broad diagnosis, or you are very certain about the phenotype or uncertain, such kind of scenario, you can choose a genetic testing. The next one is the type of disease. You need to see whether whatever the disease in question, it is monogenic, multigenic, oligogenic, what kind of disease it is. Then you can choose the test based on the type of disease. Next one is type of variations. So if you're suspecting single nucleotide variations, SNVs, so you go for Sanger sequencing or NGS based on your type of phenotype. Next, if you're suspecting chromosomal anomalies, so if they are aneuploidies, you can go for karyotyping. If you're suspecting submicroscopic deletions, duplication, MLPA and microarray are available. And even also repeat expansion. There are triplet repeat disorders which can also be tested by triplet primed PCR is available, through which you can check that triplet repeat disorders like Fragile syndrome, Huntington syndrome, and some myotonic dystrophies. If there is a specific variation in a particular gene, just like the case of sickle cell anemia, then you can directly go ahead with Sanger sequencing. If the variation is anywhere in a particular gene, then you need to see the size of the gene. If the gene is small, go for Sanger sequencing. If the gene is big, it is large, it is having multiple exons, then you can go for the targeted sequencing or whole exome sequencing based on your approach. So if the variation is anywhere in any gene, you are not sure like which gene is responsible, the best approach will be the next generation sequencing. So the first factor is diagnosis. Now I want to overemphasize here the few point that the chances of successful genetic test is directly proportional to the specificity of the provisional diagnosis and clinical details which are provided by a clinician. So it is very important to understand that a genetic test cannot be done in the isolation. It is a complementary approach along with the regular diagnosis process. It needs a good amount of input and involvement from the clinicians as well. As the laboratory person is doing, we need equal involvement of a clinician. The test results can be interpreted when a patient's records are in the place, which includes a complete physical examination. We need to have the information of the complete physical examination. You need to have the distinctive physical characteristics. Imaging test can be recorded. Then number 2 is medical history, which is very important. We need to have the information about the past illness. There are some hospitalization or surgeries performed, some medications, other laboratory tests are available that need to be placed on the record. The third one is family medical history. That is the importance of pedigree. Whenever we are getting any patient, we need to map it on the pedigree. So if there are any medical issues present in the parents, siblings, there are some unaffected siblings or affected siblings, some distant relatives, we need to have all these information together to get the idea about the inheritance pattern of the disease. The third one is other laboratory testing, like blood, urine, other biochemical tests. They also play a very crucial role, especially in the inborn error of metabolism kind of test, where the particular enzymatic test is directly will give you the clue about the disease. So we need to have such kind of information in hand. So based on the phenotype, let's see now how one can decide the diagnostic test. So now one should really look for the provisional diagnostic accuracy. If the accuracy is very high and you have easily identifiable phenotype, then you can go for the targeted NGS or the chromosomal screening test based on your phenotype. And if your provisional diagnosis is low, there is heterogeneous disorder, broad phenotypes, you are not sure about it, then go for the whole exome sequencing. So now the next question is disease in question. After diagnosis is made, one should clearly try to understand the type of disease. Type of disease means like whether it is genetic disease or it is some environmental factors which are responsible for a disease. So in the genetic disease, you need to see whether the disease is familial, where it is following the Mendelian genetics or not. It is monogenic, polygenic or oligogenic. And if it is genetic, so we need to see whether it is rare or a common disorders. Then we can look for the cause based on these information like SNVs, CNVs, repeat expansion or chromosomal anomalies. In the case of environmental, the cases must be sporadic. We need to see there are complex genetics involved. We need to see whether it is most of the time it is polygenic and common. The environmental factors can be smoking, diet, alcohol, other lifestyle factors, etc. So this slide shows the example of genetic as well as the environmental disease. In the extreme end of the spectrum, one can see the classical example of each case. So now here you can see like genetic cases like Down syndrome, sickle cell disease, hemophilia. These are all coming to this side of the spectrum. And in the environmental things like zinc deficiency, goiter, tuberculosis, all these have been mapped in the environmental part. So here you can see that diabetes has both the components. It can be either genetic or environmental. Both factors are responsible. That's why it has been placed exactly in the middle part of the bar. So similarly, like cardiac channelopathy disorders and some intellectual disabilities, they can be due to genetic as well as due to environmental factors. So therefore, it has been placed near to the middle. So now, in order to decide which test is we are going to order, or getting to know the diseases question is very important. So now, once you identified the type of disease, you can use this approach for choosing the appropriate genetic test. So now, if you can observe here, if you're suspecting monogenic, again the same thing. If you're suspecting monogenic, you need to see the size of the gene, or like if you're thinking of sickle cell or cystic fibrosis, Sanger sequencing is the answer. If it is negative, then you need to go for the higher testing. If you're suspecting some oligogenic disorders like cardiac channelopathies, you can go for the targeted gene panel. It will very well give you the result. If it is negative, then you can think about the other higher test. And the disorders where there are multiple genes are responsible, or there are some unknown or missing heritability like global developmental delay, intellectual disability, very vague and very broad phenotypes. You don't have any idea of targeted panel, then it is better to go for the whole exome sequencing in such cases. If it is negative, then only whole genome sequencing. So through prior knowledge that you have that SNVs are the major cause of your phenotype, you need to see like what kind of variations are present. Like if you are suspecting some single nucleotide variations and the SNP is, if SNV is already known to be segregating in the family, if you know the SNV and it is, you need to find out whether it is segregating in the family, go for the Sanger sequencing. If a single gene needs to be tested, again, if the small size gene, better to go for the Sanger sequencing. If the size is big, then you can go for the targeted sequencing or NGS. So if multiple genes you need to test, then you again can think of the panel or whole exome based testing. So that is also a point you need to consider, like what kind of variation you want to look for. Here, based on the variation, again I told like that was the case of SNVs. Here we are talking about the chromosomal abnormalities. If you are suspecting the chromosomal disorder, so if you are very strong about the diagnosis, like in the case of Down syndrome, like looking at the patient, you can tell whether this is a Down syndrome type phenotype, then directly you can go ahead with the karyotyping. Or if you are suspecting some Williams syndrome or velocardiofacial kind of syndrome, then there are MLPA available. You can go for the MLPA testing. And if the diagnosis is weak, you are not sure, but still you think like there can be some microdeletion or duplication present, then you can look for the, go for the chromosomal microarray testing. And if it is negative, if suppose you are not getting anything, any deletion or duplication by doing the microarray, then you can go for the NGS testing. The next scenario is repeat expansion. So if there are some triplet repeats or repeat expansion, they're like in the case, if the repeat expansion is known, it is small, like in the case of Huntington disease, you can choose the PCR based approach like TP-PCR. If the repeat expansion is unknown, or like Fragile X, the first test should be the TP-PCR. Earlier we were doing the southern blotting for that. Nowadays more simpler test TP-PCR is available. You can go ahead with the TP-PCR. If it is negative, then you can, in the case of Fragile X, then you can go for chromosomal microarray. And if it is negative, then you can go for whole exome sequencing. So now once you have done the genetic test of your choice, it is very important to interpret the results. So what is a positive test? A change known to affect the health or development in the gene or chromosome has been found. So it means like you have found a positive result. It can indicate a confirmation of a diagnosis. It can tell you whether a person is a carrier of a particular faulty genetic variant or not. It can give you an idea of increased risk of developing certain kind of cancers. Or it can also tell you about whether there is any need of further testing or not. It can tell you the implication of certain blood relatives of the persons undergoing testing. But what it cannot tell you the exact risk of developing a disorder or predictive or pre-symptomatic genetic testing. It cannot tell you about the severity of or the course of the disease. But the brightest side is this, like a positive result can direct a person towards the available prevention, monitoring and treatment options which are available there. What is now a negative test? Most of the time we used to get a negative test also. It means like a change which is known to affect the health or development in the gene or chromosome has not been identified. This is a negative result. What does it indicate? It indicates like that person is not affected by a particular disorder, and it is he or she is not a carrier of a specific genetic variant, and it does not have an increased risk of developing a certain diseases. But we need to be very cautious. We need to see the accuracy of the test. It matters a lot. The test, because the test can miss disease-causing genetic alterations, because many tests cannot detect all kind of genetic changes that can be the causative for a disease. You need to see whether the further testing or retesting is required to confirm a negative result or not. If you are very sure and the result is negative, you need to think about retesting. And watch out for the false negative. This is very dangerous. Sometimes when it occurs, the result indicate a decreased risk of genetic condition when the person is actually affected. And negative result does not indicate protection from the disease for lifetime. For example, majority of people who develop the breast cancer, they don't have the faulty breast cancer gene. But the brighter side is like a negative result can eliminate the need of unnecessary checkups, screening, tests in some cases. Inconclusive result is the most commonest scenario. Most of the time when we offer the higher genetic testing, we used to get inconclusive result. So what does it mean? When a genetic test does not give you any useful information, it can be called as a inconclusive result. So it occurs if a genetic test finds a changes in the DNA that has not been confirmed to play a significant role in the development of a disease. So such changes are known as variants of unknown significance. VOUS are very common nowadays. So due to lack of scientific evidences, it is impossible to confirm or refute a disease association. And uninformative results cannot confirm or rule out a specific diagnosis. It cannot indicate whether a person has an increased risk of developing a disorder. In some cases, testing other affected and unaffected family members can give you some clue about the type of results or the pathogenicity of the unknown significant variant. And the follow-up testing and periodic review of the scientific evidences available, it is very necessary to do the review of literature over the period of time. And the thing is, it is very common assumption, like if you are going for the higher test, it is going to give you answers for every question. It is not like that. NGS-based test cannot give you 100% solution of your problem. We need to know and accept this fact, because genomic data is being considered as a strongest pillar of the precision medicine. Exome and genome sequences are lifelong clinical resource and knowledge in terms of discovering incidental findings and novel variations. And genomic is an ever-evolving field, and a clinical sequencing report is usually prepared with the best available evidence at the time of reporting. So the unexplained cases suggest that new genetic disorders are yet to be discovered and characterized. The causes of these cases can include new Mendelian disorders, gene-gene interactions, epistasis, epigenetics, uncaptured genetic variations. There are some difficult to sequence regions in the genome, and some environmental contribution. So you need to understand these factors. So now I want to briefly touch upon the difference in between research and clinical based testing. So goal of both kind of testing are quite different. For example, in research based testing, we are not only interested in knowing the diagnosis of a patient or a condition, but also we are interested in finding the unknown genes and variants, function of the genes, like how the genes are working. This can help in the advancement in the understanding of genetic condition in a better way, and the information that we gain from, and the insights that we gain from by doing the research is also used to develop the test for future clinical use. Because of the exhaustive workup and procedures, whether the time takes for research testing is very significant. It can be from months to years, up to years. While contrarily in the case of clinical testing, you can find out an inherited disorder in an individual patient or a family within a week, or you can say within a month. But one thing is common, consent is very important, whether you are doing it for research purpose or you are doing it for clinical setting. And the utility is like both kind of tests can be used to make decisions about the medical care or the reproductive issues. So throughout the presentation, we have been discussing the uses and benefits of doing genetic testing, but it is important to emphasize here that genetic testing is not free of risk and limitations. So starting with the sampling in special cases like prenatal testing where we used to do CVS or amniocentesis can be little risky. There are some certain emotional, social or financial consequences can be significant and can create some kind of problems or tension in the families. Genetic discrimination in employment is concerning. Testing can provide limited information about the severity and progression of the disease, and treatment strategies are still not in place, and if available, they are very costly, which cannot be afforded by a common man. So the take-home message is like genome is, as soon as we are going to get more information of genome, it is going to be more complex. We need to think about the genetics. We need to look at the patient with a genetic perspective. We need to use a different genetic test we need to identify the disease, then we need to choose the test from available series of the test. Genetic counseling and prenatal diagnosis are the part of the management of the genetic disorders because most of the time treatments are not available. Thank you. This is the requisition form for the tests which are available at our lab. You can choose a different test. And here is the list of disorders. I think it is very small, not visible, which we are covering in our gene panel or hotspot mutations. The talk is open. If you have any queries or questions, please feel free to ask. So benefit of using targeted panel, like, if you have done a thorough research, a thorough literature search, and like these are the maximum 25 genes which we are interested in, you are sure about that. Suppose, then you should go for the targeted testing because the analysis part is very simpler. It will give you the more coverage of that 25 gene set, whatever you want to see, more accurate information you can get through a targeted testing. While in the case of whole exome, apart from the 25 genes, you are getting information for 22,000 genes. Obviously, you are going to end up with n number of variants. You need to do the analysis. You may get up some VOUS also, which can dilute your diagnosis. So first of all, you need to work up on your clinical phenotypes. Then you need to choose the testing. And if it is heterogeneous, obviously earlier, because targeted testing was, whole exome sequencing were very costly. Nowadays, it is coming around targeted testing. So obviously, yes, you can go for whole exome sequencing if you want because you will get so many information. Otherwise, once you are negative for targeted, then you are going ahead with the whole exome. It will make your test costlier. So it depends on what you want to do. No, not less accurate. Not less accurate, but the depth of sequencing is much more higher if your pool of genes is small in the targeted sequencing. Suppose you are getting 500x coverage in targeted sequencing, you may end up with 100x coverage in whole exome sequencing for that particular variant. That is only the thing. Maybe Pratik sir can, yeah.
them on an end. So that is how you go step by step and decide just to pick one. Another very important aspect is the excellent unit. So in our current what would I do then? And if it comes out inconclusive, then what do you do? All these scenarios you must be here a little bit planned so that you can counsel your patient accordingly and you can send to them. What is happening is we going out screening, sending this particular microarray, without knowing what is actually, the information which we are going to derive from it, how we are going to translate our patient. So that aspect. The basic take message that it's about your particular what single or multiple distributed may be called with, but are the dicombinations which are informed, whether they are single DNA level or larger than
Thank you, sir. Very well explained. So the important thing is your contribution is equally important if you want to get the diagnosis. You need to do a little homework for that. Not only global developmental delay, intellectual disability, send for the NGS. It is not like that. You are going to end up with a negative result or inconclusive result. You need to do the homework. If you have some biochemical assay, you have some mucopolysaccharidosis, you have enzyme positive, then you can go for targeted testing. Very sure for targeted sequencing. No need to go for whole exome in that case. Such kind of workup you need to do. Because reverse phenotyping is not a good idea. Most of the time, whatever happens, whenever we do the analysis, we are getting something, we are calling the clinicians, like this is something which we are getting. Now what? Then you started doing reverse phenotyping, calling the patient again, checking with the view of that particular variant. That should not be the case. At least do the homework, then send the samples. Then you will get, definitely you will get some answer. Yeah? So if you're getting a variant of uncertain, it means like there is limited information about that particular variant, or this variant is not reported anywhere in the database or the literature. Then you need to see if you're getting some homozygous variant. So there are certain ways. If you're, first of all, you need to draw a pedigree. You need to see whether it is following the recessive pattern or dominant pattern. If it is following autosomal recessive pattern, you need to check for that variant in the parents, whether both of the parents are carriers for that particular disease or variant or not. If you have multiple affected family members, so you can check that particular variant through Sanger sequencing in other affected family member. It will give you a clue. If it is not present in another similarly affected sibling, then you can rule out that variant of uncertain significance. It will turn out to be a benign one. If it is present in unaffected family member. Suppose if the variant is present in affected family member and unaffected family member, what does it mean? It means it is not the causative one. So there are few approaches. Like if you're suspecting autosomal dominant condition, you're getting some variant, you need to see whether it is de novo or not. You need to see in the parents. If it is not present in the parent, it gives you an idea like it can be a de novo variant. I mean, you need to keep few things in your mind whenever you are doing the further analysis. There are some in silico tools, but it will not tell you exactly. It will only tell you about the evidences, like scoring. It can be likely pathogenic or it is VOUS likely to be benign. There are